So let's continue with our discussion. And now let's go to dissociative disorders. So if you notice, PTSD or stress-related disorders. So let's continue with our discussion. And now let's go to dissociative disorders. So if you notice, PTSD or stress-related disorders are somehow related, or the progression of the disorder, as you can see, can lead to the next disorders that we are going to tackle, which is dissociative disorders. So, what do we mean by dissociative disorders? So, dissociative disorders involve a pathological separation from conscious awareness and range from mild to extreme. So, if you notice, I mentioned in the MSE orientation times 3. So, we ask the person about their orientation, about their person, place, and time, because we want to know if they are experiencing dissociative states. So what do we mean by dissociative states? So dissociation describes a wide array of experiences, from mild detachment from immediate surroundings to more severe detachment from physical and emotional experience. Dissociation occurs on a continuum. At the non-pathological end of the continuum, dissociation describes common events such as daydreaming while driving a vehicle. Further along the continuum are non-pathological altered states of consciousness. More pathological dissociation involves dissociative disorders. So most individuals have experienced a dissociative state at some point in their lives. Dissociation of this sort is fairly normal from time to time. However, there are, of course, 5 types of dissociative disorders, which are considered psychopathological. Dissociative identity disorder, dissociative amnesia, depersonalization or derealization disorder, and other specified dissociative disorder and unspecified dissociative disorder. We somehow all have experienced some dissociative states at this point. So, of course, maybe the experiences that we have are non-pathological, like daydreaming. We kind of dissociate from our surroundings. We can also get dissociated when we use drugs, for example, hallucinogens. So, the drugs that can get us high. That can get us high. Yeah. So, and of course, it occurs in a continuum. So there's a non-pathological and a pathological one. And in this discussion, we are going to talk about pathological dissociative states, okay, or dissociative disorders. And the first one is, of course, dissociative identity disorder. It is a rare mental disorder characterized by at least 2 distinct and relatively enduring identities or dissociated personality states that recurrently control a person's behavior. And it is accompanied by memory impairment for important information. Amnesia in the ID is understood to mean amnesia between 2 or more of the distinct identities. The host alter will experience losing time in the present, and another alter takes the place of the host alter. Rarely is the host alter aware of the time lost. Each of the distinct identities or personality has its own way of perceiving or thinking about and relating to itself and the environment. It is previously known as multiple personality disorder. DID became popularized in 1974 with the publication of a highly influential book, Sibyl, describing what Robert Reiber called the 3rd most famous multiple personality cases. It presented a detailed discussion of the problems of treatment of Sibyl, a pseudonym for Shirley Ardell Mason. Although the book and subsequent films helped popularize the diagnosis and trigger an epidemic of the diagnosis, later analysis of the case argued that Sibyl may not actually have DID. So like I said, the DID prevalence is only 1%. So it's really rare to diagnose someone with DID. And you must also consider cultural aspect before diagnosing. So for example, here in the Philippines, we have what they call quote-unquote possessions. So how do we know if it's a DID or a possession? So if it is not explained or cannot be explained by an expert, I think that's the time you need to call the priest. But just joke. That's just a joke. But DID is really rare, and there is really a need for careful consideration before diagnosing someone with DID. Usually, the person has already been diagnosed with another disorder, and then after further studies, the diagnosis is changed into DID. So if you recall previously, we talked about trauma. So having PTSD has a risk for someone who can develop DID. So, but it's really, really rare. It's a really, really rare disorder, and it requires careful diagnosis. So there's a risk, there's a possibility, or they could be comorbid with each other, or the progression of the disorder from PTSD to DID. So maybe because of the severity of the trauma. So here's the diagnostic criteria for DID. So first is disruption of identity characterized by two or more distinct personality states, which may be described in some cultures as an experience of possession. So that's why I mentioned about possession. So we must also take into consideration the cultural and spiritual aspects of the patient. The disruption in identity involves marked discontinuity in a sense of self and sense of agency, accompanied by related alterations in affect, behavior, consciousness, memory, perception, cognition, and or sensory motor functioning. These signs and symptoms may be observed by others or reported by the individual. Recurrent gaps in recall of everyday events, important personal information, or traumatic events that are inconsistent with ordinary forgetting. And of course, the symptom cause clinically significant distress or impairment in social or occupational or other important areas of functioning. And disturbance is not a normal part of a broadly accepted cultural or religious practice. Note, in children, the symptoms are better not explained by imaginary playmate or other fantasy play. The symptoms are not attributable to psychological or physiological effects of a substance or another medical condition. So, like I said, it's a very rare disorder, and you really need to study or carefully diagnose a person, carefully study the case of the person and the signs and symptoms being manifested before you can diagnose someone with DID. And just remember that it has two or more distinct personality traits. And of course, the host is not aware of the time loss, not aware of the change in personality. And of course, there is also dissociative amnesia. So the not being aware of it. So not being able to recall events, okay, that are important. And it is inconsistent with the ordinary forgetting. We also need to discuss about dissociative amnesia. And that's another disorder that we need to discuss. What is dissociative amnesia? Or what's the difference between ordinary amnesia and dissociative amnesia? So amnesia refers to the partial or total forgetting of some experience or event. An individual with dissociative amnesia is unable to recall important personal information, usually following an extremely stressful or traumatic experience such as combat, natural disasters, or being a victim of violence. Some individuals with dissociative amnesia will also experience dissociative fugue, so which is from the word to flee in French, whereby they suddenly wander away from their home, experience confusion about their identity, and sometimes adopt a new identity. Most fugue episodes only last a few hours or days, but some can last longer. So let's now look into what is the diagnostic criteria for dissociative amnesia. Inability to recall important autobiographical information, usually of traumatic or stressful nature, that is inconsistent with ordinary forgetting. So, dissociative amnesia most often consists of a localized or selective amnesia for specific events, or generalized amnesia for identity and life history. Okay? So, The symptoms cause clinically significant distress or impairment in social or occupational or other important areas of functioning. The disturbance is not attributable to the physiological events of the substance or a neurological or medical condition. The disturbance is also not better explained by the ID. It means that the person do not have another identity. Also, the person doesn't have PTSD or acute stress disorder or somatic disorder or somatic symptom disorder or major or mild neurocognitive disorder. What is important in dissociative amnesia is that it is not a DID, so meaning there is no distinct two identities and that the person is strictly unable to recall important autobiographical information. So usually it may be because of trauma. So maybe the person doesn't have any PTSD symptoms, but has dissociative amnesia. So it's recurrent, it's persistent, and the person cannot really remember what happened during the traumatic event. So of course, next, depersonalization or derealization disorder. So what do we mean when we say depersonalization? So it is defined as feelings of unreality or detachment from or unfamiliarity with or one's whole self from other aspects of the self. Individuals who experience depersonalization might believe their own thoughts or feelings are not their own. They may feel robotic, as though they lack control over their movements and speech. They may experience distorted sense of time, and in extreme cases, they may sense an out-of-body experience in which they see themselves from the vantage point of another person. Their realization, on the other hand, is conceptualized as this utter sense of unreality or detachment from or unfamiliarity with the world, be it individual or inanimate objects or all surrounding. A person who experiences derealization might feel as though they are in a fog or a dream that surrounding world is somehow artificial or unreal. An episode of depersonalization or derealization disorder can be as brief as a few seconds or continue to several years. So let's look into the diagnostic criteria. So of course, the presence or persistent or recurrent experiences of depersonalization, derealization, or both. So experiences of depersonalization is experiences of unreality, detachment, or being an outside observer with respect to one's thoughts, feelings, body sensations, or body or actions. For example, perceptual alterations, distorted sense of time, unreal or absent self, emotional and or physical numbing. The realization, experiences of unreality or detachment with respect to surroundings. Example, individuals or objects that are experiences as unreal, dreamlike, foggy, lifeless, or visually distorted. And this is also important. During the depersonalization or derealization experiences, reality testing remains intact. Because if your reality testing is impaired, it's already considered another disorder, which is schizophrenia or a possible delusional disorder. So it also causes distress and impairment in social, occupational, or other important areas of functioning. And of course, it is not because of a substance or another medical condition. And also, it's not better explained by another mental disorder, like I said, schizophrenia, panic, major depressive, acute stress, or PTSD, or another dissociative disorder. In depersonalization, you feel as though you are not in control with your body. You feel as though you are having an out-of-body experience. You feel that this is, I think, evident, especially when you experience trauma, diba? Like I said, in the PTSD, trauma is a factor, can be a factor, but of course, the depersonalization must be exclusive only to that symptom and no other symptoms of PTSD are occurring or reoccurring. And same with derealization. So in derealization, you feel like your surroundings are unreal, dreamlike, foggy, lifeless, or distorted. So that's why you often ask the orientation of the person if they know who they are, if they know where they are, and of course they know what time is it because you are asking the person's orientation or dissociative state. You're asking if they are conscious or not, okay? Or fully awake or not. So if the person seems not to be oriented, so it's also a flag whether maybe the person has another disorder such as depersonalization or derealization, or of course other disorders such as with regards to reality testing such as schizophrenia. Okay, I think this is the last for now. So thank you so much for listening despite how long this video is. But thank you very much for listening, and I hope to see you on our part 2, and we will discuss about another rare disorder, which are personality disorders. So see you on part 2, and prepare your popcorns or your study materials or any food so that it can stimulate your learning. Okay, so see you and goodbye.